The title of this project is Neonatal Abstinence Syndrome, a synthesis of literature and recommendations. Presenting this project is Alex Anderson, Pilar Hernandez, Madeline Justice, Sophie Platt, Brianna Veely, and Rebecca Long. To synthesize the research on neonatal abstinence syndrome, the articles were obtained through Baylor OneSearch and PubMed. To narrow down the search, the filters set included articles that were published within the last 10 years, peer-reviewed journals, and articles with free full text available online. Keywords searched included neonatal abstinence syndrome, nursing, qualitative, quantitative, and outcomes.
Neonatal abstinence syndrome, or NAS, is an opioid-related withdrawal syndrome, and it occurs when an infant is exposed to opioids in utero and then shortly after birth actually goes through opioid withdrawal because they no longer have that drug in their system. And every instance of NAS is unique, and the presenting symptoms vary along a continuum. These symptoms include irritability and crying, poor state control, tremors, failure to thrive, inappropriate response to ordinary stimuli, vomiting, diarrhea, tachypnea, fever, and more. And this topic is important to nursing because of the direct relationship it has with opioid use disorder and opioid addiction. In the last decade alone, prevalence of NAS has increased fivefold and is associated with other comorbidities, including low birth weight, prolonged hospitalizations, feeding difficulties, and ICU admissions. The purpose of this poster presentation is to synthesize nursing research on the effect of care bundles as opposed to solely pharmacotherapy, with the aim to improve outcomes for infants diagnosed with neonatal abstinence syndrome.
In accordance with the rise in cases of neonatal abstinence syndrome, medical research studies have had to look at the methods used and conduct an evaluation of the overall outcomes as it relates to the care of the infants in distress. Nurses use the Finnegan scoring system to guide treatment and assess infant acuity level for those diagnosed with this syndrome. One care bundle used is the Eat, Sleep, Console model, which includes the usage of the caregiver contact, maintenance of low-light, quiet environment, and on-demand feeding with the encouragement of breastfeeding. It explored methods of gentle side-to-side rocking, swaddling, and swaying to reduce irritability and increase family involvement. Implementation of skin-to-skin contact and breastfeeding methods proved beneficial to infants experiencing adverse neonatal abstinence syndrome effects through therapeutic relationship developed between nurses and mothers. Furthermore, inclusions of parental involvement, especially maternal involvement, contribute to improved outcomes with these methods. Nurses proved to be key factors in the implementations of these methods due to direct maternal contact at the bedside. Research acknowledges that pharmacological methods are used as a needed basis and typically the last line of treatment to be utilized when all of non-pharmacal techniques has been initiated. Overall, implementation of non-pharmacal care techniques improve patient outcomes by decreasing the length of stay by 67%.
So the research evidence synthesized for NAS treatment in infants shows a negative correlation between the use of the more traditional methods of pharmacological treatment, such as that of morphine, and the length of stay for infants following birth. So, rather than using further pharmacological opioids and medications to help manage NAS symptoms in infants, nurses are educated and encouraged to use non-pharmacological techniques such as side-to-side swaying, rocking, and swaddling in order to promote better health outcomes and decrease length of stay. Part of this includes exhausting all non-pharmacological options before even turning to pharmacological treatments, as well as staying current in the knowledge regarding evidence-based practice for NAS treatments. Lastly, parental involvement and knowledge are a cornerstone in successful implementation of non-pharmacological interventions. Parents can be involved through skin-to-skin contact and breastfeeding, and nurses continue to play an essential role even in this area as they can provide a therapeutic and supportive relationship to encourage active parental involvement in the current NAS case, as well as preventing others in the future.
After an extensive synthesis of research, we found that many studies suggest using non-pharmacological techniques should be used to their fullest extent before turning to pharmacotherapy like morphine. Nurses can continue to advance health literacy in their communities by using the Eat, Sleep, Console model to evaluate progress and incorporate appropriate interventions in babies with NAS. This model utilizes a different scoring system to measuring infants' ability to eat, sleep, and be consoled instead of the previously used Finnegan model. The key differentiator is that the eat, sleep, console model considers normal infant behaviors that might skew results, therefore encouraging the use of pharmacotherapies when it's not truly indicated. NAS stems from pregnant women partaking in chronic opioid use throughout their pregnancy. As nurses, it's imperative we educate our communities to protect vulnerable populations. Initiating statewide and local educational programs will do two things. First, it will increase awareness of prevention practices and consequences of substance abuse, such as NAS, and secondly, it will educate mothers on a variety of treatment options for NAS so that they know pharmacotherapy is not their only option. Another recommendation is encouragement, education, and enablement of birth mothers to breastfeed their babies who are diagnosed with NAS. Breastfeeding has been shown to decrease adverse symptoms of NAS like difficulty feeding, irritability, and failure to thrive. Evidence shows that breastfeeding also decreases the average length of stay and reduces the need for possible drug interventions. Taking care of a child with NAS can be daunting and potentially frustrating. For that reason, organized caretaking around the clock is essential. Volunteer sign-ups should be in place to provide respite for parents and caretakers. This will decrease the burden that comes along with caring for a complex infant with NAS. Finally, if pharmacotherapies are being used in conjunction with non-pharmacological therapies, a standardization of scoring system, timelines, and weaning precautions should be developed. There's currently no widely accepted standard of care for infants with NAS, but by utilizing the techniques and recommendations highlighted above, we maximize the opportunity to see continued improvements within this population and significant improvement in symptom management, shorter lengths of stay, and an overall reduction in NAS instances and morbidity.